This is Dr. Andrew Yan at USC, and we are going to focus in this video on total knee replacement in the setting of post-traumatic deformity, specifically in patients who have sustained a prior tibial plateau fracture with removal of hardware complicated by malunion, bone loss, and distorted anatomy. These patients often present years after their initial injury, once arthritic changes have taken hold. And the arthroplasty surgeon must navigate not just the arthritis itself, but also the residual deformity and bone loss from the fracture and its associated treatment. So in this older individual, a patient has a post-traumatic arthritis following prior open reduction and internal fixation of this tibial plateau fracture. The patient had a plate which has been subsequently removed. And although the plate stabilized the initial fracture, there is residual deformity with depression of the lateral tibial plateau, you can see here, and alteration of the tibial slope. Radiographs show also a clear difference in the degree of bone quality in the tibial metaphysis. If we look at the left side, we can see nice calcifications, and here we can see a graying or washing out of the bone stock in the metaphyseal diaphyseal region. So these issues, the loss of tibial height, as well as the alteration of posterior slope and the loss of bone mass in the tibial metaphysis, will present key reconstructive challenges in dealing with this associated valgus deformity. CT imaging allows us to understand the deformity before we even begin. We get a three-dimensional model, and then we can break this down into the femoral side and the tibial side. The femoral side in this patient is relatively straightforward since the fracture had been on the tibial side. And so here we have the coronal, the axial, and the sagittal, and we can set these at the standard parameters of 0 degrees mechanical alignment, or anatomy, 0 degrees mechanical alignment, 8 millimeters off the medial femoral condyle, which is the thickness of the implant, 0 degrees internal rotation in relation to the transepicondylar axis, and we can maintain posterior offset at 8 millimeters, make sure we don't notch. All the complexity in this patient, however, comes on the tibial side. So we can initially set it for a neutral mechanical alignment, and then we can see the large void here, which could become an issue if we were to use standard implants. We can look at axial rotation and set it for 0 degrees, but we can also see here instead of a normal posterior slope, we have a reverse slope from this depression injury. And so this is our starting point, and this is how we would start with traditional mechanical alignment: 0 degrees, 0 degrees, 3 degrees slope. However, with robotics, we can make very subtle, precise changes that are specific to the patient's anatomy. So traditional conventional, we would accept the 0 degree mechanical alignment from the prior slide, but with robotic surgical planning, we can assess the deformity, and this patient has a flexion contracture with a valgus deformity. So instead of taking a mechanical alignment cut and then doing secondary releases to the posterior lateral capsule, as well as the iliotibial band, we can make subtle changes on the femoral and tibial side so that those soft tissue releases won't be necessary in order to achieve symmetric gaps. And in this situation, we'll add 1 degree of valgus to the femur. We'll still maintain 7 degrees off the medial femoral condyle. More importantly, we'll take 3 degrees of valgus, so we'll go from 1, 2 to 3 degrees of valgus on the tibia, but you can still see the keel tracks centrally. And then we'll keep it at neutral rotation. We can see the trochlea matches very well with the femoral groove. We can set it at 0 degrees rotation. And from the sagittal, we've maintained the offset posteriorly, and then we made sure we did it notch. We have the same good medial lateral sizing, and then we've restored the 3 degree slope. And by making these subtle changes, we can balance the knee ahead of time without having to do secondary releases after we make neutral cuts. And I can see we've restored symmetric gaps in extension. We have 15-15, and as well as flexion on both sides. If we made our cuts, we'll then place our trial implants and then reassess our balance to confirm our symmetric gaps. And this is one of the most important parts of the procedure, because this then confirms our preoperative balancing as well as our preoperative planning. And we can see here with the trials in place, We're back to a neutral alignment. We have 19 millimeters on both sides. We have a symmetric extension gap, and the leg is back to neutral. And so here we are with our post-operative images. Remember, we started with a post-traumatic deformity with associated malunion, prior hardware removal, large bone void, as well as a reverse float. And what we've been able to do by making these small adjustments, we've restored a neutral alignment between the femur and the tibia. The components are well mated. The tibia is central. We have an extended stem to bypass the metaphyseal defect. And most importantly, we have a very symmetric extension gap. And when we look at the lateral, we can see we've maintained our posterior offset, and we're in neutral alignment down the tibial shaft. So this case illustrates the importance of preoperative planning, advanced imaging, and implant selection in the setting of post-traumatic deformity. And by anticipating all these alignment traps, by planning soft tissue and bony corrections, it's possible to restore stability and balance even in the most complex settings. Thank you very much.